Tim, do you want to start us off with the first question?
Okay. So just to start off, what inspired you to pursue pediatric research and more specifically research in OCD?
Yeah, great question. I think sort of a number of things. One of the things is that I've always really liked working with kids and youth. So right from when I was a young adult myself as a lifeguard and swim instructor, and then as a med student, I really liked working with the families and youth at the children's hospitals. So that's just something I feel like kind of drawn towards. Maybe I'm a little bit silly, so I can relate in that way. But then with the part about research, I think the part that's really exciting about doing research with children and youth is how resilient they can be. So they have this potential to sort of rebound, bounce back, flex, with things and recover, when they have appropriate treatment. So it's a really kind of exciting group to work with for research. And then with respect to OCD, I think it's a great example of an illness that can be very disabling, but that can really improve dramatically with appropriate treatment. So, and we know that this can lead to better adult outcomes. So yeah, I think it sort of just inspires me.
Yeah, that's a great story. It sounds like it was very natural kind of pathway for you. And then, yeah, just kind of, so some people might not necessarily know what OCD is, and just so for the people watching or listening, can you explain what OCD is? And as someone who has OCD and has always wondered what the cause is, maybe like what are some of the findings of your own or maybe alongside others that suggest what childhood onset OCD is caused by?
Yeah, thanks so much for asking that. I think this is a really important question because obsessive compulsive disorder, I think, is one of the most misunderstood mental illnesses. It's used a lot in social media or films or TV, almost like it's sort of a cute or complimentary, not a big deal kind of thing to have, or sort of like a personality trait. I'm so OCD. But I think people don't necessarily mean to be hurtful when they say things like that, but I think they are regularly, because really it diminishes the incapacitating nature of OCD. We wouldn't call it a disorder unless it significantly impacted people's quality of life, if it got in their way of them being the person they could be, or if it's causing a lot of distress. So when we say OCD or give that a diagnosis, it's not sort of a funny, cute thing. And many cases just take hours and hours out of the lifetime of every day of an individual dealing with it. So maybe I'll just quickly say what OCD is. So OCD is a psychiatric disorder. It's a brain-based condition. It's no one's fault if they get it, any more than it's a fault if you get asthma or diabetes. It's something that's associated with obsessions, which are recurrent, intrusive, unwanted thoughts. So not being like obsessed with a guy, because that's, positive thoughts. When we talk about OCD obsessions, it's intrusive, it's something you don't want. And no matter what you do, it keeps coming back in your head again and again. And then the piece that sort of makes OCD unique from something like generalized anxiety disorder is that there's sort of a behavior that follows from that and gets connected with those thoughts. So it's a behavior, something that the individual learns that if they do that well enough for enough times, then this horrible, awful feeling will actually finally go away. So, and then the more they do that thing, whether it's checking, whether it's doing a specific prayer, whether it's hand washing, whether it's rearranging things, any number of things, the more they do that, I think the more you can feel drawn into feeling like, how am I going to get through my day unless I do that thing? And then it just grows and grows and grows. And, we say the OCD is like we work with kids and youth, so we use terminology like OCD is a bully. And the more you give it, the more it takes. So it doesn't go away on its own. So it affects about 1% to 2% of the population. In terms of different countries, the rates seem to be very similar. And it doesn't seem to be increasing or decreasing over time. It just seems to be something that's there. In terms of what causes it, like many psychiatric conditions, it's probably a combination. So it's everyone's an individual, but what we can say overall is that genetics play a role. So the genes that you inherit from your mom and dad can make you more or less susceptible to getting OCD. But then, you know, things that happen in your life, or maybe at different points of brain development, maybe if there's sort of negative events around the birth, like some complications, that may increase risk, and certain other factors can contribute. So it's not like we can say, you know, one particular thing causes OCD in an individual. It's like when enough factors come together, and then often there's sort of a final straw. It might be a life stressor, but that doesn't mean that that one stressor caused OCD, and that if they didn't have that one stressor that they never would have had it. It's sort of more an accumulation kind of thing.
Yeah. So as somebody so involved in the OCD community, what does a typical day look like for you as an educator and researcher?
Yeah, so I'm pretty lucky. I love my job. So I'm pretty fortunate to get to work in a lot of different areas. I'm kind of a dreamer type. I like to believe in the potential for making change and growth and all of that kind of thing. And in my job, I guess I get to see it play out a number of different ways. So on a typical day, I have many different roles often. So I have the role of a doctor working with my patients and their families, as a teacher to students who are training. So it could be medical students or residents, as a leader of some team within the OCD hospital. So the OCD program, also brain behavior and development theme at the BC Children's Research Institute, and also as a researcher. So getting to look or explore or think of new ways to try and come up with answers that are practical, that may help improve the lives of patients. And then as a supervisor to people who are wanting to learn how to do research. So I get to do a lot of different things in the course of a day. It's not boring.
Yeah, it sounds like you wear a lot of hats. And I also just really like your description of OCD and what it is, and what maybe does or does not cause it. Because I feel like a lot of times people try and find one single route because they like having answers, but it's just not that easy and it's not that conclusive. So I like the way you put that. Yeah.
Yeah, absolutely. And I think a lot of people carry guilt about it. And I think in general, people with OCD are the most lovely, bright people, very sensitive and empathic that you could kind of meet. But one tendency that can go along with OCD is sort of over responsibility. So almost taking on the burden more than you should. So sometimes thinking, oh, well, if I should have just done this or that, or suck it up, then I wouldn't have it. Well, no, it's no more than you could sort of suck something else up and like choose to not have diabetes or an inflammatory bowel disease or whatever. I mean, it's, you know, it is kind of what it is. So
yeah, no, I've definitely felt that at times. So yeah. And then our next question was just about how, yeah, it looks like you've done a lot of research, and it focuses primarily on the biologic and phenotypic treatments for the childhood onset neuropsychiatric disorders, or, you know, OCD, stuff like OCD. It's a mouthful to say. But maybe could you just tell us more about your research, so that specific hat that you wear on certain days, and its outcomes?
Sure, yeah. So there's a lot of big, fancy words there, but effectively, I guess what it means is, I mean, one thing that stayed steady for me over the last 15 years when I've been a researcher and clinician is that my focus tends to stay on OCD and related disorders. But over time, I've looked at many different aspects. So I think it started off in genetics. So looking in terms of what are the genetic contributors, and that kind of led me to thinking more about families, because we know, genes run in families. But also looking at how OCD impacts the family environment, not just how the family impacts the OCD. And then somewhere in the last, I don't know, 5 to 10 years or so, I'm becoming more interested in treatment. And what are the things? So we do have some proven treatments, evidence-based treatments in OCD, which is great. So cognitive behavior therapy, exposure and response prevention in particular, it's the gold standard. And there are a number of meds that can help as well. But it's probably suboptimal. We would want it to be able to help more people. So I've become interested in looking at different ways we could have add-on treatments. So the focus of the research has changed over time, but in terms of different aspects around OCD, but sort of the disorder and people living with this condition, that's been something that's kind of stayed consistent.
Yeah, and just following up on that, what would the add-on treatments look like? Like with that?
Yeah, so there have been a few different things. We know one of the biggest aspects of OCD is that, like I said before, it's kind of like a bully. It takes over and it gets not only a person with OCD to do things, but it also will often get moms or dads to change things in the environment. They may need to do things a certain way for it to be acceptable, or maybe the youth is, you know, not able to go to school, so they're doing kind of workaround. So one of the treatments we look at is working with families. So working with parents, helping to explain OCD to them and helping and coaching them to sort of decrease or lessen accommodation of the OCD, and doing some parent management training, because for some, especially younger kids, sometimes when you're trying to get them to face their fears, of course, who wants to do that voluntarily? So for a small group of kids, they may have outbursts and anger and aggression, and then parents don't know what to do, and they're sort of feeling hostage, like feeling held hostage by the OCD. So we've done some work with parent management training. And also it's just really stressful. So we also had a trial of parent mindfulness training. So not necessarily the kids or youth with OCD doing mindfulness skill training, but the parents. And we found that that helps them to tolerate those times when they see their child being so upset by the OCD. And what happens is parents see it and then they're wanting to kind of rescue their child, which is, you know, a natural reaction. But if it's actually giving into the OCD, you sort of end up feeding it. So I think we're very open to many different things that may help. So those are the non-medication approaches, but we've also looked at things like glutamatergic medications. We now have a treatment trial of an anti-inflammatory medication, kind of like Advil, but using that in OCD, because it does seem like there's inflammatory processes involved in OCD as well. So both medication treatment approaches, but also other things to add to the non-medication CBT approach.
Yeah, parents definitely play a huge role in helping their children recover from OCD. And I know that like when parents satisfy their children's compulsions, like it can be really unhealthy. And yeah, and our next question is that you founded the Pediatric OCD Clinic and Research Program at the BC Children's and Women's Health Center. And we were wondering if you could elaborate on what these programs are and how you develop them.
Sure. Yeah. So the program is centered, it's a UBC centered program, but located at BC Children's Hospital. And the goal, we have a provincial mandate within British Columbia to provide resources related to pediatric OCD. And we have three sort of foci, if you will. The first one is providing clinical services. And the next one is training or teaching, because we know we can't, we're a small team, so we can't be the ones who are providing all the OCD treatment across the province. So trying to work with community providers. And then that third piece is doing research that's going to sort of help to improve outcome. So I think one of the things I'm proud of is that, so I was recruited here from the States, from MGH and Harvard, and was given a lot of support in terms of setting up a team. So really this is something, you can't just do it one person. So really everything we do is team-based, and I'm really lucky to work with great psychologists and social worker and lots of trainees. So we really kind of come together and work together to try and meet all of these different needs. And one of the neat things we did, although it's not that unusual now, but it was at the time, is to try and integrate research into all the clinical work that we do. So basically everyone coming through our program would have an opportunity to be involved with research.
Oh, wow. Yeah, that definitely expands things. Yeah, and I just circling back to what you said earlier about the parents, and it almost seems so paradoxical that, what you think your child wants because it's, you know, what their OCD is telling them, turns out to be what actually feeds it more and perpetuates the cycle. So I think that was a really good point that also Tim brought out too. Yeah.
Yeah, it's so it's so true. So I'll often, I co-lead the parent groups, and I'll say it's one of those few areas in parenting. Like often in parenting, it's hard to know what's the right answer, and there's different theories and all of that kind of thing. But generally, if you follow your gut instinct, you know, you're fine, and the child is fine. But with OCD, it's like upside down world. So if you're following your gut, actually what you could be doing is making the OCD stronger, thinking, oh, it'll make them feel better right now, but actually it's just feeding the OCD. So it's just really hard. Well, it's obviously really hard to have OCD, but also, you know, very hard for parents to learn that they have to kind of go against those instincts of trying to do the thing that's going to make their child feel better just in that moment, you know.
Yeah, and I can imagine for parents who don't have OCD, understanding just the thought process behind it would almost seem, you know, obviously it's impossible to know what it's like unless you have it. And so just kind of understanding, well, you want to do that, then do it. You know, it seems, yeah, definitely. So I find it really interesting that you guys are touching not only the person, but the people around them.
Yeah,
so,
and very often parents can think like somehow they can talk someone out of OCD or rationalize it or try and go through, well, if you think this and you think that, then you shouldn't do this. But again, it's like trying to talk someone out of asthma or diabetes, because sure, you can understand the logic behind it. You know, if you would just stop wheezing, if you would just get your bronchi or to stop constricting, then, you know, there's not a problem. Or if you just get your pancreatic cells to work properly, then you won't have the diabetes. Well, it's kind of like the same thing. You can't talk someone out of OCD because it's not logical. You know, it wins the debate every time.
Yeah, and it's the fact that it sounds so ridiculous when you say like, oh, talk your pancreatic, you know, out of doing those kind of things, you know, and the fact that generally when you say that for, you know, mental disorders, it doesn't have the same kind of comedic element. I think that shows the different perceptions of, you know, the physical ailments versus in the mind.
Yeah, and I think that's where some of the stigma comes from too, where people feel like, oh, why don't you just change it? Well, I mean, if you could change it, it's never fun having OCD. No one chooses to have it. So if you could change it, you probably would have. So yeah, it's not that simple, you know, just like it's not that simple to choose to stop wheezing, you know, if you've got asthma.
Yeah, exactly. And then just cycling back to all the work that you've done, have you faced any challenges in trying to make strides when applying your research to real life applications? So I guess this would be like you working with families and stuff like that.
Yeah, yes, I have. And I'm always sort of torn, right? So I love doing clinical work and working directly with families, but I also like sort of the bigger picture. And sometimes if you're, you know, going deeply into the world of basic science, the connection between, say, like certain parts of a gene and someone's life, it feels like a bit of a stretch. So I spent a number of years looking at, you know, genetic contributors, being involved with a genome-wide association study, international study, looking for genetic variants that confer risk for OCD. And as it turned out, I mean, I think it was successful, you know, I was able to get grants and that kind of thing and publications. But I found myself being more interested and intrigued about sort of family aspects. So then we started looking at, you know, what are the impacts of OCD on families, and developed an OCD family function tool. And I think similarly, when I'd started off looking at cognition in children and youth with OCD and looking at if those are inherited aspects, so even brothers or sisters who don't have OCD yet, but they're at risk for OCD, we looked at those markers and found some interesting findings like, you know, planning tasks, there's differences there. But really in the end of the day, I ended up more interested in the practical pieces. So then we took a look at, you know, what is school functioning like for kids or youth living with OCD? And then one of the studies we're doing now is a follow-up. It's by a med student who's looking at what is the process of disclosing to school, or did you decide to tell the school, or did you decide not to? And what were the reasons? And if you did, was it helpful? Was it not? So I think I try and, even if if I'm not feeling like the work that we're doing has clear practical impacts, what I've tried to do is think of some aspect that might have more clear implications, that could sort of be more meaningful for someone who's not a scientist and knowing how to read these, fancy pants articles and stuff.
It's so important to try and like incorporate research into real life, because sometimes it can just be kind of not rewarding if there's like no application to it. And what you said about the schools is really important, because I know it's so contextual. Every school can be like different, and some schools can like overreact and some schools can just like not do anything. And yeah, it just really depends, right?
Yeah, totally. And that's so I think where I feel like I'm sort of, okay, you could call me maybe an expert on OCD, but I've only become the sort of expert because of the people I've worked with. So it's the kids and youth and adults who have OCD who've taught me over the years. So what I like is being able to, work with families and youth and kids. And I like brainstorming and thinking about things, but sort of listening about the stuff that has relevance, so that's what makes me happy, I think.
Yeah, so kind of related to that, you've done so much research and supported the OCD community so much. And I was wondering, big or small, what is the most rewarding aspect of your involvement within the OCD community?
Yeah, I think there's so many rewarding aspects, but the one that gets me hooked, I think the most, is this feeling I get now or then. I can't predict when it's going to happen or what exactly it's going to be, but some sort of signal that maybe something that our team has done has improved the lives of people, in some meaningful way. And it could be, like a conversation with a patient of mine or a card from them, or it could be like seeing people who've gone through psychology or psychiatry training where they're out in the community and now they're taking on patients because there's such a shortage of OCD treatment providers. If they might shoot me an email and say, hey, that was great, or I was thinking about one of the things, that you taught us. Or it could be, I find we get funded on a study that is kind of in an area that I think is really exciting and meaningful, or if we published a paper so that what we've been able to do here in Vancouver is going to be accessible throughout the world. So yeah, I think it's that irregular reinforcement. So from time to time, I just get a sense that, oh yeah, we are doing something meaningful.
Yeah, I actually really like that phrase, irregular reinforcement, instead of like having some kind of continual thing. It's just spontaneous. That sounds really special.
Yeah.
Yeah. And just what you were saying about like making your research really applicable into real life. I think the fact that like, even when you're just talking about the families and disclosing information to schools, I think it's something that almost everyone with OCD has to have faced in their lifetime. And it definitely, to me, feels relatable. And so I think what you're doing sounds really, really special. And then just kind of expanding that to everyone else listening, how would you encourage other people to partake in helping people with OCD or other neurodiverse people, or just everyday ways to advocate for the community?
Yeah, I would say don't get too hung up on what the exact right thing is to do. Kind of get involved in whatever way you see fit. It doesn't need to be a huge thing. It could be just a very small thing. It could just be doing a little search online to see if there's possibilities or things that you could do. And there's so many different ways to contribute. I think often people feel a bit shy or inhibited. It's like, oh, I'm not an expert. I'm not the person to do this. Well, if not you, who? And this is the same thing for me. I've ended up tripping into all kinds of areas in my career where I'm like, I don't know that much about it, but then you learn more and you figure out the stuff that you're good at, the stuff maybe you're not so good at, and then you focus more on the positive area. So I'd say, don't be shy and don't worry about it needing to be something huge. Even this, what I've found over the years is even the smallest thing, it can be just a little thing that I've done, I haven't really thought about since. And it could be someone comes back 5 years later and says, remember when I talked to you in the hallway that time? You didn't know this, but this meant blah, blah, blah. So, so I think not being your own enemy about what you can do and not underestimating your own ability, just to kind of pitch in and help in whatever way works. And I would say, just on the note, if there's anyone who watches this who's a youth, a teen or a youth with OCD, we're still running the study on and interviewing individuals with OCD about their experience about talking to schools or not. So if you're interested, shoot me an email.
That's a good plug.
Yeah, shameless plug, but
yeah, whatever.
yeah.
No, but I really like what you said about not worrying about being right, because I feel like it's strange, but there's like a sense of perfectionism when it comes to helping other people, when it's really just about engaging with them, and it's not about being perfect. And that should be the last worry. It should just be about your relationship with that person and what you're trying to help them. So yeah, it shouldn't be fearful. Yeah,
exactly. And you can learn, like just keep trying, even if you try something it didn't go so well, try it a different way, right?
Yeah, exactly. Yeah, so I think that's all for today, but thank you so much. It was really special to talk to you.
Yeah, it was great talking with you guys, and keep it up. I think you're fantastic.
Thank you.
Okay, take care.
Thank you so much. Bye.
Bye.